Hello everyone. In this lecture, we are going to study bipolar and related disorders. Here is an overview of today's lecture on bipolar and related disorders. First, we will ask the question, what are bipolar disorders? Defining the condition and distinguish it from depressive disorders. Second, we'll explore the key features focusing on the symptoms of manic, hypomanic, and depressive episodes. Third, we'll look at the causes and risk factors, including biological, psychological, and environmental influences. Finally, we will discuss support and intervention, covering treatment approaches and strategies to help individuals manage these disorders. Bipolar and related disorders are characterized by alternating depressive and manic episodes. Depressive episode involves symptoms such as depressive mood, anxiety, loss of energy, and hopelessness. People may also experience poor concentration, feeling of guilty, or even delusion of persecution. On the other hand, manic episode is marked by an elevated or irritable mood, grandiosity, and overactivity. During this period, individuals may engage in impulsive or risk behaviors such as excessive spending, gambling, or reckless acts. Bipolar disorder can be classified into different subtypes. Bipolar 1 disorder will full manic episode occur, often alternating with depression. Bipolar 2 disorder, which involves hypomanic episodes and major depression. And cyclothymic disorder, characterized by chronic mood fluctuations that are less severe but more persistent. Overall, these conditions illustrate the complex and fluctuating nature of mood disorders, requiring careful diagnosis and management. Now let's move on to the key features of bipolar and related disorders. Bipolar disorder is characterized by manic and hypomanic episodes. To diagnose these episodes, at least 3 or more key symptoms must be present. Some common symptoms include inflated self-esteem or grandiosity, a decreased need for sleep, pressures, speech, and excessive talkativeness. Patient may also experience racing thought, distractibility, increased goal-directed activity or risky behavior such as excessive spending, sexual indiscretions, or foolish investment. Manic episode is more severe. It involves abnormally elevated or irritable mood that lasts at least 7 days, and it causes significant impairment in daily life. On the other hand, hypomanic episode is less severe. It lasts at least 4 days and is noticeable but not severe enough to cause marked impairment. In addition to manic or hypomanic episodes, individuals with bipolar disorder also experience major depressive episodes. To meet the criteria, a person must have at least 2 weeks of depressive mood or loss of interest or pleasure, causing significant impairment. Key symptoms with at least 5 or more required, including depressive mood most of the day, loss of interest or pleasure, significant changes in weight or appetite, sleep disturbances such as insomnia or hypersomnia, psychomotor agitation or retardation, fatigue or loss of energy, feeling of worthlessness or excessive guilt, poor concentration or indecisiveness, and recurrent thought of death or suicidal ideation. Together, the alternating manic, hypomanic, and depressive episodes form the core clinical picture of bipolar disorders. Here we have bipolar 1 disorder, 제1형 양극성 장애. The defining feature is that the individual has experienced at least one lifetime manic episode. This manic episode may be preceded or followed by hypomanic or major depressive episodes. Key features include manic episodes that last at least 1 week and cause marked impairment or even require hospitalization. These episodes may also include psychotic features. In many cases, manic episodes alternate with major depressive episodes. Overall, bipolar 1 disorder leads to significant distress and functional impairment. Next, we have bipolar 2 disorder, 제2형 양극성 장애. This condition requires at least one hypomanic episode and one major depressive episode with no history of full manic episode. The key features are hypomanic episodes lasting at least 4 days, characterized by elevated or irritable mood and increased energy. Major depressive episodes are common and even very impairing. Importantly, there are no psychotic features during hypomania. The core of bipolar 2 disorder is usually chronic, with functional impairment arising mainly from depressive rather than hypomania. Finally, cyclothymic disorder, 순환성 기분 장애. This is a chronic, fluctuating mood disturbance that includes numerous periods of hypomanic symptoms and depressive symptoms, but these do not meet full criteria for hypomania or major depressive episode. Symptoms must last for at least 2 years. Or at least 1 year in children and adolescents. During this time, there are many periods of hypomanic and depressive symptoms with no symptom-free interval lasting more than 2 months. Importantly, there is no history of full manic, hypomanic, or major depressive disorder. Cyclothymic disorder is essentially a milder but more persistent form of bipolar-related mood disturbances. Now, let's move on to the possible causes and risk factors. Let's begin with the biological factors underlying bipolar disorder. First, neurotransmitters play an important role. The low level of norepinephrine are often linked to depressive episodes, while reduced serotonin combined with increased norepinephrine tend to be associated with manic episode. Next, we see changes in brain structures. Research has found that people with bipolar disorder may have smaller basal ganglia or cerebrum, as well as abnormalities in regions such as amygdala, hippocampus, prefrontal cortex, and white matter. Finally, there is strong evidence for genetic contributions. Bipolar disorder show high heritability and severe chromosomal linkage. For example, chromosome 1, 4, 6, 10 through 13, 15, 18, 21, and 22 have been implicated. Biological factors are only part of the picture. Psychological influences also play a major role. Stressful life events can trigger both the onset and relapse of episode, especially when interpersonal conflict or academic or occupational stress are involved. Cognitive style also matters. A negative attribution style, meaning a tendency to explain events in internal, stable, and global terms, can make individuals more vulnerable. In addition, excessive goal striving can create instability. When goals are not met, depression is more likely, and when goals are exceeded, mania may be triggered. Behavioral sensitization is another factor. Over time, people may become increasingly sensitive to stress so that even minor stressors can set off episodes, often shaped by interpersonal dynamics. Lastly, low social support is a significant risk factor. High levels of family criticism and expressed emotions increase the likelihood of relapse. Now let's move on to support and intervention for bipolar and related disorders. First, pharmacological treatment remains the foundation of care. Since the 1970s, lithium and other mood stabilizers have been widely used to reduce the severity and frequency of episodes. Today, pharmacological treatment is still the primary intervention. However, medication alone is not enough. Evidence shows that combining medication with psychoeducation and cognitive behavioral therapy lead to better outcomes. Psychoeducation helps clients and families understand the illness, recognize early warning signs, and prevent relapse. CBT, on the other hand, support clients in managing negative thought patterns and building healthier coping strategies. Overall, an effective approach to bipolar disorder is multidimensional. It combines pharmacological treatment, psychotherapy, and strong social support network. This integrated strategy offers the best chance for symptom control, relapse prevention, and improved quality of life. In this section, we explore the complex landscape of bipolar and related disorders. We begin by defining the disorders, emphasizing the alternation between depressive and manic episodes, and introduced the three main categories: bipolar 1 disorder, bipolar 2 disorders, and cyclothymic disorders. We then reviewed the key features of manic, hypomanic, and depressive episodes, highlighting their diagnostic criteria and clinical impact. Next, we examined the causes and risk factors ranging from biological contributors such as neurotransmitter imbalances, brain structure abnormalities, and genetic heritability, to psychological and social influences like stressful life events, cognitive styles, and family dynamics. Finally, we looked at support and intervention with pharmacological treatment, especially lithium and mood stabilizers at the center, complemented by psychoeducation, cognitive behavioral therapy, and strong family and social support systems. Across these discussions, one message stands out: bipolar disorder is highly manageable when recognized early and treated through a multidimensional integrated approach. Medication, therapy, and supportive network together provide the best outcomes for long-term stability and quality of life. I hope this lecture has helped you gain a deeper understanding of bipolar and related disorders. Thank you for your attention.